I'm Louise Dembry, and I'm going to talk about the approach to antibiotic stewardship programs with a focus on implementing a program. So I think when we start here, I want to get us all to understand what I mean by antibiotic stewardship. And so there's one definition that I like. It's the one that the CDC uses, and they talk about a set of commitments and actions that are designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. So that said, I think we need to remember that we tend to think that antibiotic stewardship programs, or ASPs, are simple and complex, but they can be complex and challenging programs to design, implement, and administer. And that's because there's a complexity to the medical decision-making surrounding antibiotic use, and there's variation in the size of hospitals and the types of care that's provided. And so there has to be flexibility in how ASPs are implemented. But as with anything that has to do with performance improvement, it requires a culture change. And this is something that can also add to the challenge of implementing an antibiotic stewardship program. You also need to have a solid team of professionals and commitment of hospital leadership to make it successful. So when we talk about goals of antibiotic stewardship programs, I think it's important to recognize that really what we're trying to do is optimize the treatment of infections and reduce adverse events that are associated with antibiotic use. Sometimes people tend to think that our goal is really about decreasing cost. There's some component to that, but it's a very small component. Also included in this, hopefully an outcome of a good stewardship program, is we'll be able to reduce resistance, but the center of this is optimizing patient safety. Back in 2016, the Infectious Disease Society of America, Society for Healthcare Epidemiology of America, and the Pediatric Infectious Disease Society of America came out with a paper going through recommendations for implementing an antibiotic stewardship program. And they made 28 recommendations in the categories of interventions, optimizing antibiotic use, microbiology and laboratory diagnostics, measurement, and also special populations. This is an important paper for anybody to read who's looking to implement an antibiotic stewardship program. It goes into much more detail than I'm going to be able to go in here, but I want you to be aware about this. And they also grade their recommendations as to the strength of the evidence behind it and whether it is something that something that hospitals should all do or might consider doing depending on what their situation is. So a really good paper to review. That said, the CDC had put out back in 2014 what they call the 7 core elements for antibiotic stewardship programs. And I'm only going to talk about a couple of these, but one of the really big ones is a leadership commitment and having a dedication to the human, financial, and information technology resources needed to not only implement a program, but to sustain a program. And also this ties into accountability and having drug expertise. And then I'll talk a little bit about action, which is where you want to start thinking about implementation of evidence-based interventions that it can improve antibiotic use. And we want to think about, when we think about actions, about at least implementing one or more recommended actions, and you can read about some of those in that IDSA paper. Of interest is, back in 2016, surveys were done on hospitals by the CDC, and only about 65% of hospitals in the United States had a stewardship program that met all 7 core elements. So their goal is that by 2020, 100% of U.S. hospitals will meet all 7 core elements of antibiotic stewardship. So this really becomes important, not just implementing the program, but making sure all elements are included. So the leadership commitment, as in anything we do in performance improvement, is really critical to the success of the program. And it can take any number of forms. So remember, we have to be flexible about implementing an antibiotic stewardship program and looking at your own facility, what your resources are, what the issues are that have been identified. But some examples of commitment from leadership can start as simple as a formal statement that the facility supports efforts to improve and monitor antibiotic use, It may include stewardship-related duties and job descriptions and annual performance reviews, maybe not just for the people who are involved in doing stewardship, but for anybody who's prescribing potentially. Also, a commitment from leadership is that they ensure staff have sufficient time to contribute to stewardship activities, because it is a multidisciplinary approach, and so it's not just one or two people or a small team that does this, and it takes time. Another thing that shows leadership commitment is if they support training and education. This could be training and education that's offered online, having people go away to conferences, bringing educators in, anything like that that supports growing the knowledge base. Also, commitment is ensuring participation from many groups to support stewardship activities, and as with anything, there may be also the component of financial support to grow the capacity of the stewardship program. So we're talking about implementing stewardship. There's some examples of implementation strategies would be designating someone in the C-suite or an individual who reports to the C-suite to be accountable for the outcomes of the program. You also can think about a policy for the stewardship program to include all the 7 core elements as outlined by the CDC. Integrating stewardship activities into ongoing quality improvement or patient safety efforts in the hospital is a good way to be able to use that infrastructure that is already available. And I think something that's always important when we talk about implementing any new kind of program like this is there needs to be a reporting structure. You want to ensure that the information about the activities and the outcomes of the program are shared with not only leadership and the hospital board, as well as stakeholders. They're the ones who are going to be able to help you with overcoming barriers that may come up, but also to celebrate successes and to support sustainment of the program. Other implementation strategies can be statements from the board, hospital leadership, to all providers and patients highlighting the commitment to improving antibiotic use, and as I already mentioned, supporting training for those people who are going to be leaders of stewardship and people who are frontline staff who need to understand more about what stewardship is and their role in that. So here is something, I'm not going to go over everything in this slide, but this slide is a good one. It gives you a reference there, but it summarizes some key elements of successful antimicrobial stewardship programs. So really important is it needs to be a multidisciplinary approach, and I'm going to spend a little time on that in the next few slides, but it's need to be careful when implementing a program. You just don't have a few people who are responsible for it and be the only ones who are committed and involved in determining what the focus of the program is going to be in the direction. So there needs to be a multidisciplinary approach and get buy-in from many stakeholders. I've already talked about the leadership commitment and active involvement. You also want to think about ways that you have some IT support. This is bigger than I can talk about today, but you want to think about an implementation, how IT can help you and leverage your electronic medical record system to support the goals of the stewardship program. And also to be able to measure what the program is doing. Is it meeting its goals? And within this, you're going to want to look at a combination of process and outcome measures. So just something to keep in mind, those things where successful programs have had the ability to not only implement the program and sustain it, and they follow really all those key components, and many of them mirror the CDC's 7 core elements. So when we start with this, I kind of say, we think about this, it takes a team. As I said, you can't just have a couple individuals doing this and say, go at it, and it's your job to take care of everything. You need to think about who the team is going to be. And you're going to have to think about who your leaders are going to be. So we tend to identify and think about a stewardship program leader. Like to have a single leader who's responsible for the outcomes of the program. Generally, these have been infectious disease physicians. They've been shown to be highly effective in this role. We need to keep in mind that not all facilities will always have an infectious disease physician. So think about somebody who has an interest in this area, who also understands the clinical aspects of care of the patient and also is a respected leader, can sometimes also play this role, may require a lot more training, but that support should be made available to them. You also need to have a pharmacy leader, and you'd like to identify a single pharmacy leader who will co-lead the program, ideally a pharmacy leader who's had infectious disease training. There are more and more pharmacists now coming out with a specialized training, and it's important to seek that out if at all possible, and they can help train other pharmacists to be part of the stewardship program and do some of the basic work of the program. And they're really responsible for working to improve antibiotic use. Clinicians are very, very important. You really want buy-in from the clinicians. You need to get feedback from them. Infection prevention and healthcare epidemiology as well. They're the ones who track and trend resistance patterns, hospital-acquired infections, and they'll have an idea of where some of the issues are when we're going to start talking about some of the initiatives and where improvement can occur. Quality improvement, because as I commented on, they already have a lot of the structure about how to improve performance. You want to include them. The laboratory is very, very key. What kind of tests are going to be offered? How are the results going to be presented? Does it support what the stewardship program is trying to do? And information technology. And I want to take a moment and just mention also nursing. We often don't think about nurses as part of the stewardship team, but they are key group to this. They review culture techniques and make sure that cultures are collected properly. This is a key piece to antibiotic stewardship. They can review culture results with treating physicians and pharmacists. They also are at the bedside and are part of the team monitoring the response to antibiotic therapy and can give feedback to the treating clinicians and pharmacists. They also can assess patients' ability for oral intake and what their clinical status is. This becomes important when you start looking at some programs to change intravenous to oral therapy, which is part of stewardship. They're also key for educating patients about potential adverse events associated with antibiotics and also reminding us to initiate what's called antibiotic timeouts. This is where after 48 hours of therapy, we take a step back and we assess, is this still the right therapy for the patient? We look at the culture results and determine whether antibiotics should be continued or changed. And they can do that with the treating physician and pharmacist and are really key for reminding people that it is time to take that time out. As with anything that involves change can be very challenging, and so some of the things that help support success of change, and anything in antibiotic stewardship is usually a change, you've got to have clear goals. Be very clear about what you're trying to achieve. And need to get people on board and having them all believe that there is a need for change. And this is where data can be important. Data talks, data speaks. It tells you where there may be issues and get everybody on board and say, yes, this is an area that we can improve on. You want to get all stakeholders involved in participation in the planning, not just in the building of the program, but how the program is going to look, what are the goals going to be, how are we going to determine what's success, and those are the metrics. And you want to be able then to show what your progress is and results, and this is where you're looking at measuring outcomes as well as process measures. So how do we know that we're getting where we want to be? What will those metrics be? Who's going to collect them? Where are we going to get that data from? And all that helps if that's all planned ahead of time, and then that makes change much easier for people because they understand where they're going. And so we have to think about this too, that a range of implementation options that might be useful, and each hospital is unique and needs to consider which options might be most effective based on discussions with providers. And so this also helps support success of change. So when you're getting started, as I talked about, you want to identify the people who are going to be part of your team. But you also need to think about having an antibiotic stewardship committee. This is generally something that you want to have the hospital leadership, sometimes it's the medical board, it depends on the structure at your hospital, to charter this committee. It gives it support and visibility, and this is the group that then can report up to leadership about successes, challenges, barriers, the next direction where it's moving to. So think about that stewardship committee, bringing together relevant stakeholders, and generally the chair here will be the person who is the point person for the antibiotic stewardship program, and it sometimes can be a combined co-chair between the infectious disease clinician or other clinician designated in that role and the ID pharmacist. Sometimes it's the clinician. But think about what works for your committees at your hospital, but a stewardship committee can be very helpful. And you're going to want to think about, when you're starting out, what will be a priority area? And you want to be careful about not introducing too many changes in many areas simultaneously. That can be very difficult. So start with a single priority area. And to determine this, you're going to want to review your existing data on antibiotic use. If you don't have that, you may want to conduct a focused needs assessment. If that's something you can't do, then sometimes just an expert opinion if you don't have data, or discussion within the stewardship committee about what should be our initial single priority area. And usually you want to start with something, as I would call it, the low-hanging fruit, something that there's good consensus on, relatively easy to do, and can be a quick win. That really helps get buy-in and provide support for your new program. We talk about priority areas for stewardship programs. The CDC defines essentially 3 categories. So a broad category, pharmacy-driven infection syndrome specific, is the third. So broad category areas would be like antibiotic timeouts, which I already mentioned. After 48 hours of antibiotics, you take a step back and you assess the antibiotics. It can be a prior authorization program where you need to get approval before starting an antibiotic, or a prospective audit and feedback, which is after antibiotics are prescribed, that the stewardship team reviews that and provides feedback to the ordering clinician about the appropriateness of the choice or whether there's a better option. Pharmacy-driven priorities are things like changing from intravenous to oral antibiotics, making dose adjustments, dose optimization, putting in place automatic alerts, for example, if there's redundant therapy, such as 2 anti-anaerobic agents that have been prescribed. And also things around time-sensitive auto-stop orders. One of the more common ones is stopping preoperative surgical antibiotic prophylaxis within 24 hours of the surgery. When talking about infection syndrome specific initiatives, those are things where you would have guidelines for treating community-acquired pneumonia, urinary tract infection, those kinds of things. So those are syndromes. So those are the 3 broad categories. Those are the 3 categories. And so you'd want to maybe pick a single priority area in just one of those categories to start. And when you start, then you have to ensure that you have the appropriate policies and guidelines in place for that priority area so that everybody is on the same page and they know what's expected of them. And then you want to educate your staff and publicize the stewardship campaign. You want people to know what you'll be looking for, what you expect them to do, how will we know if this is successful. And then you would implement the stewardship activities that are targeted at that priority. And you want to try not to initiate too many activities for that priority. Usually you're talking about 1 to 3 activities that would be at the core to improve that priority area that you've chosen. Something that's realistic to achieve, especially when you're starting out, something that maybe you can do in a relatively short period of time, and that might be, say, in a 3 to 6 month period of time, so that people can see the wins and they can feel that this is something that is doable. So when you look at this, you also want to think about it's going to be an intervention that's important to your facility. And then you're going to select that change. You test the change, so you put your interventions in place. Again, you may not want to have more than 1 to 3 or so interventions, something where you can test whether that's worked, then you implement that change. And you're constantly thinking about that plan, do, study, act cycle of quality improvement, and engage the clinicians, communicate with them, standardize where you can, and again, think about when you're starting out those things that are easy wins, the low-hanging fruit, the right thing to do, something that's easy to do. And then you've always got to think about how you're going to monitor and evaluate this, and think about a combination of process measures as well as outcome, so that you can look at whether you're achieving the goal that you want to achieve. So evaluating a process would be looking at, say, are policies and guidelines followed as expected. The outcomes really is, are your interventions improving antibiotic use and patient outcomes? So those are some pretty kind of broad categories and way you would look at it. So examples of some initial initiatives you might want to do for a stewardship program is, I commented, an IV to oral conversion program if you don't already have one. Have protocols and guidelines about automatic conversion. Get the clinicians involved, everybody to agree when those conversions will occur. Optimizing dosing. Focus maybe on renal dosing. Again, have protocols and guidelines with clear direction, which antibiotics will be included in that and how they'll be adjusted, so it's not a surprise to the clinicians and they've agreed to it, and that they're supportive of pharmacy doing this and helping them care for their patients. Formulary restrictions. This is where you're going to be targeting more around selection. I would say these are not easy to do if you're starting with a pre-authorization, but think about doing the 48-hour review or the timeout and asking people to always, do a 48-hour timeout and document it in the chart that they have thought about this. If they continue the antibiotic, but that they've thought about it. And then de-escalation, kind of call it de-escalation 101, those things that are relatively easy. For example, switching therapy from vancomycin to one that's a targeted agent when the culture comes back, not MRSA, but comes back with methicillin-sensitive Staph aureus, and you can change that. So this is something that I think is very interesting, and at the end I give you some slides with references, and you can look this up in much more detail. But this is a conceptual model of key drivers for reducing inappropriate antibiotic utilization. And it's called a driver diagram, and along with this goes a change package, which is much more complicated and detailed than I can explain here. But think about this as a map for improving antibiotic use. And you want to be able to visualize your improvement effort, and you connect your interventions to a larger goal. So you're trying to really lay out the various processes to lead to your optimal antibiotic use. And you have your processes that are what are called the primary and secondary drivers. Whenever you're doing something like this is a very broad one shown here. And again, if you're interested in looking at this, you can look this up, and it gives you many more supporting materials on how to use this type of system to improve antibiotic use. But recommend that you not attempt to implement all the interventions at once, and that you pick a few key ones and then you implement them. You study, you see if they've been implemented, if they have impact, and you do feedback, and you try to support those interventions till they're really in place, and you can add more interventions in time. So you need to be very careful about this and tailoring it to the areas that most need improvement. So that means that you might not do something facility-wide. You might choose to do something in a certain unit or a certain area, and trial it there first and see if you can get that to that intervention to work and to get it to be part of the stewardship program before you were to do something maybe more broad. So again, this is something, it's just a concept and it's an idea of how you can look at approaching your initiatives and designing them and mapping them out so people can see what the plan is. And I think that it's something that it could certainly used for a lot of things around performance improvement, and it would work also for antibiotic stewardship. So I would say in summary, there's a lot that can be done when you're just starting out and implementing an antibiotic stewardship program, but you've got to also customize it to your facility. Think about the type of facility, the population served, and the health profile there. Because really you're talking about wanting to make sure you also have a team approach and a comprehensive understanding that assesses includes all stakeholders within each clinical practice setting, and they must all be good stewards in the use of antibiotics. So the bottom line is antibiotic stewardship programs support providers to make the optimal treatment decisions to improve the chance of cure, and that is the ultimate goal and the overarching reason to have antibiotic stewardship programs. I'm going to end here with just a few resources. Some of the ones I commented on already in this short presentation. I would also suggest that if you go to cdc.gov, they have a whole section on antibiotic stewardship programs. They have them for acute care hospitals, outpatient facilities, as well as long-term care and other healthcare settings. You get a lot of good ideas there about where to start in implementing your antibiotic stewardship program. Thank you.